Good evening, everyone. Today we're going to discuss the use of O-arm and 3D navigation in scoliosis surgery and deformity correction. As we know, in patients with scoliosis and spinal deformities and kyphosis, a lot of patients have dysplastic pedicles, atrophic pedicles, or even in some cases, absent pedicles. So placing the instruments in these patients is critical. Medial or lateral perforation carries the risk of violation and injury to vital structures, including the nerves and vital organs of the body. That's why the role of 3D navigation and O-arm based navigation is very important. But the important question is, why not just C-arm based navigation or a freehand technique or X-ray based navigation? There are several limitations of the C-arm based technique or the X-ray based navigation, especially in the high thoracic spines, cervical spines, obesity, and patients with severe deformities. There is superimposed bony architecture. There's the rib cage, the shoulder, the scapula that comes in and obstructs the vision in patients with osteoporosis. And in patients with deformity, the visibility can invariably be poor, and that can lead to misplaced pedicles and misplaced instrumentations. Now, this is a typical example of a X-ray of a patient with scoliosis, a congenital scoliosis, where the visibility of the pedicles in the AP and lateral planes can be very poor and can lead to misplaced instrumentations. This is the high thoracic fixation. The scapula, the shoulder blade, the humerus can come in your way, and this can lead to misplaced screws and the high thoracic vertebra, especially at the T2, T3, T4 in scoliosis correction. And osteoporotic spines as well. The visibility is extremely poor in the high thoracic or thoracolumbar junction or in patients with obesity. Now, there is enough literature to show that the perforation rate in pedicle screws in the lumbar spine can range from 17 to 34%, whereas in the high thoracic spine from 23 to 55%. That's very high incidence of perforation rate with a freehand technique. That's where the role of O-arm or O-arm based navigation comes into, with accuracy is almost 99%. And so this is the typical elements for navigated spine surgery: a navigation system with a localizer, a patient reference frame, surgical instruments with attached trackers or optical markers, a monitor. And this is the O-arm, which is basically an intraoperative CT scan. The patient is positioned on the operation table. The O-arm is a 3D CT scan that comes into the picture. It scans the patient with a three-dimensional shoot. These images are transferred to the software, and then the O-arm goes out of the operation theater. Now the surgeon comes in and he performs the surgery under 3D navigation without exposure to any radiation. And the placement of screws is nearly 100% accurate, which you can confirm again with another shoot after the surgery. So this is the patient with adolescent idiopathic scoliosis corrected by an O-arm based navigation technique. You can see on the right side, the pedicles are calibrated by the pedicle probe and with the use of navigation. So the placement of screws is almost 100% accurate. This is a child with syndromic scoliosis with about 140-degree curve in the thoracolumbar spine from T5 to L3. Now, these are significant rotations and dysplastic pedicles. The risk of perforation can be very high, and the risk of misplaced screws can be very high in these patients. So in this patient, we did the stage 1 transthoracic release of the spine, followed by stage 2 on the same day, posterior thoracolumbar fixation from T5 to pelvis under the O-arm and 3D navigation. And there is a fair correction of deformity in this child. In patients with high end deformity like kyphosis or angular kyphosis, congenital kyphosis, semivertebrae, vertebral column dissection can be safely done with the use of 3D navigation and use of a navigated drill. You can check the depth of your drilling easily under 3D navigation and safely perform vertebral column dissection up to 2 or 3 levels in these patients. The 3-level VCR in a patient with congenital kyphosis. This is another child with congenital kyphosis with a hemivertebrae, and as you see in the CT scan, she has absent pedicles at the level of T5 and T3, T4 on the right side, and tight stenosis. So this correction was done under navigation and O-arm with the use of navigated drill, and a safe correction was obtained in this patient. Another patient with a rigid deformity, the visibility is, you can see the pedicles are barely visible under the X-ray. So this was done under 3D navigation and O-arm, and a fair correction of deformity was obtained in this child. This is another patient with scoliosis and syrinx and ulnar carry malformation, a large syrinx extending from C3 to D12. Stage 1 foramen magnum decompression was done, followed by stage 2 scoliosis correction after 6 months, and the fixation was done from about T5 to L3, and the safe correction was done under 3D navigation and O-arm control. Another patient with errors in the area of scoliosis, fair correction of deformity under O-arm and navigation. Now, congenital scoliosis is another challenging patients who have multiple hemivertebrae. The pedicles are atrophic and can lead to misplaced screws in these patients and injury to vital structures. They are very rigid curves, and correction is difficult in these patients. So with the use of navigation, you can place screws at the maximum levels and obtain a fair correction in these patients. Another patient with congenital scoliosis and multiple hemivertebrae, a fair correction of deformity with the use of O-arm and 3D navigation in this patient. So in these patients with high-end deformities with dysplastic pedicles, the solution is 3D navigation. It has less radiation, almost no radiation to the surgeons. It's less time, and it's almost 100% accurate. It's more precise. The most important advantage which I see in spine surgery of this O-arm and navigation is almost zero radiation to the surgeon. And yes, radiation is a big deal nowadays. Radiation hazards, as we know, are dryness of eyes, fatigue, tiredness, burning of skin, numbness, neuropathy. And in advanced cases, even we have seen cases of infertility, cataract, cancer reported in the literature. That's why we must take care of our own safety. And the biggest advantage of this O-arm based navigation is zero radiation to the surgeon as he's standing outside the operation room during the surgery. There is enough literature to show that the CT scan based navigation is about 99% accurate as compared to the freehand technique. So it's more accurate, more precise, and less radiation. And that's the new way to go. Thank you.